All right, good afternoon, everybody. My name is Lisa Herzig, and I serve on the planning committee for the Duncan seminar. And our next presentation is going to be from these two lovely ladies here, and they're going to be talking about promoting optimal feeding and nutrition. And I want to introduce you both to them. This is Nowak Cooperman, who's a dietitian here at Seattle Children's, and also Peggy Smith, who's an occupational therapist. And Kim has been working in several different clinics at SCH and first came to us in 1995. And Peggy has joined us just 2 years after that and has had several different responsibilities throughout the hospital. And they are both a part of the intensive feeding program as well. So without further ado, I'm pleased to announce Kim and Peggy.
Okay, so can you hear me from standing here? Works okay? Okay, great. So good afternoon. Peggy and I, we're going to do kind of a tag team approach. We're not going to be like me speaking all at once and then her speaking. We're going to go back and forth. So hopefully that'll help keep you guys awake because it's kind of a hard time of the day. So thanks so much for inviting us to speak on this important topic. And as Lisa so graciously did, she introduced us, and we have been here for a while. We both have been here for over 20 years, so yeah, we've been around. And one thing I wanted to say is it's great to see so many parents in the audience, and especially parents of children that I personally work with, and it's really great that you're here. And thank you. Okay, we don't have anything to disclose, but we are open for, any gifts. No, just kidding.
So yeah, I want to thank you for staying this long for this portion of our talk. And we hope it's informative and interesting. We hope that you'll be able to describe some of the nutrition and feeding challenges of children with Spina Bifida throughout their development, and that we encourage you to learn the factors that contribute to overweight and underweight with these children, and that you'll be able to identify the signs and symptoms of dysphagia associated with Chiari II Malformation, and that you will be able to develop interventions to manage the nutritional and feeding challenges with kids in your own practices.
We have structured our presentation to discuss the pitfalls by life stage to illustrate the strategies that can promote the best outcomes. There are several factors that contribute to possible problems with feeding and nutrition. The majority of children have a Chiari II malformation, which may cause dysphagia. Energy needs are typically lower because of lean body mass is less, so risk of obesity is actually increased, although we do see quite a few children who are underweight. Physical challenges often result in less participation in activities, and I think we did hear about that a little bit in the previous talks. There is reduced sensory awareness, so this increases the risk for developing wounds. And that's particularly important, especially during surgery and recovering from surgery. Children have bowel and bladder issues, as well as an increased risk of osteopenia and bone fractures. So we'll discuss these further with our case examples.
The typical course of a newborn here at Seattle Children's or anywhere with Spina Bifida is the most critical time and it involves intense medical interventions. As you have learned from our other presenters, the first few weeks of life are when they have their back surgery closure or back closure surgery, and they're being monitored very closely for the signs of a more involved Chiari II malformation. These signs help the neurosurgeons with clinical information regarding the decision to place a shunt. Nutrition and feeding and support are the key to optimal recovery. The baby and the parents are provided with frequent visits from therapists and nutritionists to learn how to position, feed, and monitor the baby for concerning signs such as apneic spells, stridor, coughing, coughing with feeding, wet vocal sounds, or hoarse or high-pitched cries. Our first example is a newborn who presents with an L5-S1 lesion. OT and PT and nutrition are closely monitoring this baby as part of the initial consultants per the myelomeningio newborn pathway, which Dr. Walker shared with us this morning. Prior to the surgery, the baby can be given breast milk, but he's not allowed to go to the breast. The baby has, this baby had surgery to close the back and had an externalized shunt placed. And the baby is now positioned solely prone or inside line. He is encouraged to breastfeed as early as possible, and he is getting expressed breast milk via the bottle. Protein as well as vitamin and mineral supplementation are provided to help with wound healing. The inpatient infant team are seeing him several times a week to support he and his mother and father with feeding and positioning strategies. This newborn phase of child development is when the therapist and nutritionist have a very large role to play in the child and family life. A lot of education and coaching of the family is necessary for them to prepare to take their child home. That's right. So here is a child who has had her back repaired and is now able to go to the breast. As you can see, it was necessary for her to have a shunt placed, which is visible in these pictures. The therapists are monitoring the quality of her breastfeeding mechanics. They observe her suck, swallow, and breathe synchrony and her during her breastfeeding sessions. She is being supplemented with vitamins and iron at this time.
Okay. Follow-up in clinic routinely takes place 1 to 2 weeks after discharge, as we saw in the newborn pathway. This is when the child is seen by the nurse practitioner and typically with OT and PT. Nutrition follow-up is typically scheduled later at age 2 to 3 months, and this is coordinated with another visit with the neurodevelopmental team. Additional evaluations for feeding may be needed, and they might be scheduled, or communication with a local feeding therapist is made if that's already been set up and in motion. It's recommended that children with spina bifida be routinely monitored in a clinic that specializes in the ongoing care of spina bifida.
Seen.
Seattle to have one, but I know in certain regions of the country it might not be as easy. Our next case example is an infant. So as mentioned previously, the first visit with nutrition is within the first 3 months of life. This 2-month-old infant was seen as part of the meningomyelocele pathway. At this point, weight gain was noted to be slower than expected, with weight for length decreasing from the 75th to the 25th percentile. Growth assessment is important and plotted on the WHO growth charts. During the nutrition interview, the family noted difficulties with latching. They were giving supplemental bottles after breastfeeding, but the infant was not taking in the recommended volume. The feeding evaluation was useful in identifying some problems and provided recommendations for the positioning, nipple type, and other strategies. Formula feedings were increased in calorie density. With this case, formula powder was added to the breast milk to make it a little higher calorie, which we do frequently around here. And we adjusted the recipe for mixing, or you can adjust a recipe for regular formula to do this. Local feeding therapy was recommended with close nutrition follow-up in 1 month to make sure that goals were being met.
So here's an example of a prone positioner. You saw, I think Solveig had this on her slides. which was fabricated by our infant team. This one's a little worn. The OTs and PTs make these. And the babies are placed prone on this surface to ensure that they avoid rolling or pressure on their surgical site, to let the spinal closure to heal completely and safely. Sideline is also approved position for these first 2 weeks of the baby's life. And then the baby is fed and cared for as much as possible in these positions, but they can be held for feeding. And here is the little one with her IV, and she's just so cute. She's so cute.
One thing we love about our job is we get to play with babies. Okay, I wanted to just bring up the fact about latex allergy, and we had quite the discussion about latex earlier, and like Dr. Walker said, there's no latex falling from the ceiling in here, I hope. But it is a question that is brought up. But the issue has really largely been resolved by the use of universally latex-free products in hospital settings and medical procedure areas. But latex allergy can still be present. And if it is, certain foods that cross-react with latex may need to be avoided. And those are listed here. The Spina Bifida Association recommends that only foods that actually cause a reaction be eliminated because you don't want to have any unnecessary restrictions.
In this example, we're going to talk about a toddler who has started receiving birth to 3 services in the community, 1 time per week. Their therapists have started to visit in the home, and they've noticed that this little one is taking too much of cow's milk and is not progressing to age-appropriate solids. The therapist is concerned that the toddler is not actively moving as well as they expect. So the child's weight gain velocity is accelerated, and there is an increasing risk of overweight and obesity. The therapist decides that a feeding evaluation is needed to tease out factors contributing to this child's progression to solid foods. Could it be dysphagia, sensory issues, family dynamics, environmental factors? She recommends establishing routine opportunities to consume at least 3 meals in the high chair with a goal of no more than 20 ounces of 2% milk with transition to a cup. And the community therapist has discussed these recommendations with the family and has contacted the neurodevelopmental nurses to alert them to these concerns and nutrition and feeding and the mobility concerns as well.
At age 3 years, this child presents to clinic with ongoing growth concerns. Weight percentile has declined steadily, resulting in underweight status as evidenced by body mass index less than the 5th percentile. At age 3, we use the CDC growth charts, and because children are typically standing, even though sometimes children with spina bifida don't stand, we have to use them anyway, so that's what we use. Okay. Goals are, I'm glad that got a laugh. It's really challenging to get accurate length measurements and height measurements in kids with spina bifida, I'll just say that. And so, but BMI is sometimes really not very useful, and I will put that in my report sometimes. But the goals are for steady and predictable growth, and if BMI is something that is looked at as accurate at all, we want it to be above the 10th percentile, ideally, but below the 85th, because at the 85th, it increases risk of obesity. The family is interviewed for current feeding concerns for this child and note long meal times and difficulty eating that include gagging and choking. The child has been followed really closely in clinic. Their intake was evaluated and estimated needs were calculated. For this child, several strategies have already been tried, and this happens pretty frequently, to help improve weight gain. And these included higher calorie formula, changing the food texture, increasing calories with nutrient-dense foods and food additives. The family has been adding calories with fat such as butter, oil, cream, mayonnaise, etc. I think some of the families in the audience can remember some of these conversations that we've had. Sometimes they work, sometimes the kids are like, "Oh, there's cream in that milk? I'm not touching it." They know exactly. You put a teaspoon in there and they're like, mm-mm. You try to put butter on it, they're like, mm-mm. So you try. So this child had a feeding evaluation, and a swallowing study provided some more needed information, as the child was not consuming enough and actually found to be at risk for aspiration. So a gastrostomy tube was recommended to supplement safe oral intake with texture and liquid modifications. And I just want to mention that gastrostomy tubes are beneficial with some of these children and are useful to boost a child's intake and to get growth back on track and reduce the stress and anxiety around feeding and development.
So you may have heard about, or you have heard about the Arnold Chiari malformation. We've talked about it using the term, the preferred term is Chiari malformation 2 or Chiari II malformation, and now, or the Chiari malformation. There's lots of, so I was interested in learning more. Hans Chiari, who was the pathologist who produced reports back over 100 years ago over several patients. And Julian Arnold, he published one single report 3 years after Chiari published his initial report. And so the classification system that Chiari produced has not significantly changed over the 100 years. And so he identified 4 malformation types of the herniation of the hindbrain. And this other guy, Cleland, was another author that wrote one paper. So that's why we refer to the Chiari II malformation as the kind of the gold standard for describing the hindbrain, which Emily talked about earlier. So as we mentioned, the Chiari II malformation is the one of the malformations that Chiari described as associated with myelomeningocele. And dysphagia is one of the key signs that there's more severe brainstem involvement. Of course, breathing is an important piece too, and that's also highly looked at, but that's not the topic of our talk today. So we assume we have breathing going on, but those are the big areas that the neurosurgeons, the therapists, the nurses, everyone is looking at when the baby is just born and after the surgeries to really assess their function and if they can safely eat and breastfeed or bottle feed. And though there is imaging and likely there could be a shunt placed, clearly identifying this dysphagia is an ongoing process. If these signs and symptoms persist and then a weight loss trend is developing, the child may require an NG tube and perhaps later a G tube. Chiari II malformations typically occur with lesions above the sacral level. As a clinical swallow assessment is initially utilized to assess the child's swallow function, and if the child is displaying some of these signs, they should be monitored more closely. Parents are most likely will have raised concerns as they have been trained in that NICU phase to be watching for these neurological changes. A video fluoroscopy swallow study would then be the next step to further evaluate the child's swallow function and safety. And these findings all, of course, should be reported to the medical team immediately. Our next example is a 10-year-old boy, or 10-year-old with lower lumbar myelomeningocele, who presents with being overweight, picky eating, problems with chewing, and feeling as if the food is getting stuck when he's swallowing. His weight and body mass index has been increasing for the last 2 years, and it is common for the linear growth to slow after 2 years of age, which can lead to overweight. The Center for Disease Control growth charts are used to assess the nutrition goals. We hope to see steady growth and weight gain with a body mass index goal between the 10th and the 85th percentiles. Our 10-year-old boy has a history of problems with feeding since his infancy. He had challenges with breastfeeding, and he did not progress to solids well. He does not like vegetables, and his family has stopped offering them to him. A feeding evaluation is completed, and the stuck feeling is only occurring when he has harder to chew foods like meats and raw vegetables. It is found that he does fatigue when he's chewing, and he seems to avoid vegetables because they look gross. Yep. And he's encouraged to drink water or liquids when he's with his meals, along with well-chopped meats. And this boy is also starting to become aware of his body and would like to increase his fitness level. He has expressed the desire to be more active and build up his muscles. His family is supporting him in swimming and walking with his manual wheelchair while encouraging him to eat more fruits and vegetables. His energy requirements may be maybe 25 to 50% less than his ambulatory peers. This is due in part to his lower lean body mass. Weight loss may not be a realistic goal, but slowed weight gain may be achievable. And education must be tailored to his age, keeping in mind any issues of intellectual disability, which may be more likely with the diagnosis of spina bifida. Oh yeah, I get to keep talking. I get to talk a lot. So the previous example, case example, is a child with rather typical sensory processing challenges. It is so common to hear any child say that they don't like vegetables when they haven't even tasted them. The Steps to Eating, which is a tool developed by Kay Toomey, PhD, can be a helpful strategy for parents to help their child to start exploring vegetables and any foods for that matter, but vegetables are usually a big one. And other whole foods will especially benefit from exploring from these strategies. The point is that they don't have to get to the last step every time they encounter a new or familiar food. Playing with their food, making designs, pictures, letters, using their school skills is a good way to play with their food. Poking, cutting, letting them use their fine motor skills, exploring with the food. You play along with them and they will love it. And it really will help them become more comfortable with the food. The concept of interoception, which describes the child's inability to tune into their own internal sensations, can also include bowel and bladder awareness, sensations, as well as emotional awareness. But this also can be seen as the child's lack of awareness of their hunger and their satiety cues. So therapists who work in the area of feeding encounter children with that have these problems frequently. We help to educate parents to the child's sensory processing awareness and encourage parents to alter their view of their child's unique relationship with food. This understanding by the parent can provide a more calm environment for the child to gain comfort and confidence when encountering and challenging new foods and set a path for their journey of eating.
Okay. Our last case example is of an adolescent girl, and she is quite complicated. As we know, by the time children reach adolescence, there's usually been quite a few issues that have come up in their lives. So this is a girl who has a history of a decubitus ulcer on her left heel. She's at risk for this because she has reduced sensory awareness below the level of her lesion, as this does increase the risk for skin breakdown and wounds. Weight has been an issue for her and has been fluctuating up and down. Her last weight, or her current weight, is about 10 pounds down from a year ago. Since she is mainly sedentary, it's likely that her fitness level is low and energy expenditure less than typical. She has been trying to manage her weight, and we do see this quite a bit, by skipping breakfast and avoiding milk to reduce calories. To heal, there is a need for adequate protein supported by adequate energy, so weight loss is really not compatible with optimal wound healing. So it's important to get a good diet history and to assess adequacy of what she's actually eating, and also to identify possible contributory factors to other problems such as constipation and risk for urinary tract infection. It's also important to screen for restrictive eating behaviors, as there have been case reports of eating disorders in adolescent girls with spina bifida. And I wonder if this has something to do with what we heard earlier from Dr. Holmbeck, that children, or girls in particular, are less accepting, they have decreasing acceptance of their own physical appearance. And of course, we know in the general milieu of social areas that girls are very at risk for body image issues. So a diet recall for this young lady revealed inadequate intake of calcium and vitamin D, as well as high-quality protein. She had a blood test for vitamin D, and it was low. We do screen for vitamin D deficiency, especially in this area in the Pacific Northwest. We're more at risk for that. And it was low. We do often recommend multivitamins for children at all age, especially those who have difficulty eating and tend to have maybe a restricted kind of intake. Fluid intake in this case was variable and likely not meeting optimal goals. Just wanting to mention that constipation and bowel and bladder incontinence is seen in varying degrees in about 90% of individuals. Other problems do include increased risk of urinary tract infection and kidney stones, so fluid intake is really important. We really want to get an idea on how much fluid they're actually drinking, because sometimes children will actually restrict their fluid intake because they really don't want to have diaper changes, perhaps in school or in other social activities, and it's a way that they control their incontinence. As we know, low intake of calcium and vitamin D is associated with decreased bone mineral density. However, individuals with spina bifida also have increased urinary calcium excretion, which increases their risk of this. For this young lady, goals were agreed upon by using motivational interviewing techniques. We heard earlier it's really important to involve the actual child in discussions about their health care. And with adolescents, sometimes you need to talk to them individually too. You might even have to ask the parent to leave the room or get permission from the child that the parent stays there with you during the appointment. But this young lady, she agreed to eat some breakfast. We got her to increase some calcium-rich foods and to increase her total fluid intake. We talked about fiber, and she did identify some high-fiber foods that she would increase or try to eat more of. And she did also agree to take a vitamin with iron. She also said that she would try to take a 30-minute walk in her wheelchair 3 times per week and maybe work on increasing that as she got more used to that. So we did have a plan to meet with her at her next routine visit. So in summary, I want to just talk about the nutrition challenges and summarize a little bit. There definitely are lots of challenges to securing optimal nutrition in children with spina bifida. And weight issues can really go both ways. While overweight is more common, underweight is definitely an issue, and I have many patients and families that I talk to about that. Certain medications may contribute to lower appetite and poor weight gain. And as we've learned today, the attention deficit problems have medications that can do this. We know that bowel and bladder issues are almost ubiquitous in every patient. We know that certain nutrients, particularly calcium and vitamin D, are at risk for being low, which are important in minimizing losses in bone mineral density and reducing the risk of osteoporosis and bone fractures. We know skin breakdown and wounds can occur due to the lack of sensation, and that it can increase as wound healing is needed after surgery. Also, in adolescence, children often don't allow their family or other members to observe them.
Sorry.
That's okay. Uh-oh.
Oh my
Uh-oh.
I'm in the wrong spot. Sorry.
Just go back one. Okay. Here, I'll do it.
Sorry.
I'll do it. Sorry about that, guys. Let's get back. So another thing I just wanted to mention is that the prevalence of processed food also can contribute to these challenges. So nutrition counseling through the life stages should be focused on promoting independence in self-care as much as possible, taking into account their physical and cognitive abilities. And I think we've heard that theme all day, which is, hitting home. Learning about their own nutritional needs and limitations are part of the process, as well as learning how to tune into their hunger and satiety cues. So the goal is to increase awareness of their hydration and nutritional needs and promote the optimal intake of nutritious foods so their bodies can function well.
So to summarize, my portion is that the Chiari II Malformation, we understand is a serious part of the complex that involves in children with spina bifida. And considering this percentage, it's interesting that we don't have greater data to support or to understand the prevalence of and the severity of dysphagia. It's either children with severe dysphagia will get a G-tube or and then children who don't seem to and are swallowing well don't. And we don't really have a good understanding of the fine-tuning portions of that. And as we gain more insights and technology and research into the areas of feedings, we hope to be able to enhance the lives of the children with the diagnosis of spina bifida to help them to develop their optimal potential. And these next few slides are a list of our references that we used to prepare for our talk. And we thank you.
Hi, my name is Elizabeth. I have a question about the nutritional guidelines for adults with SB or any resources that you guys may know of for nutrition specialists with adults with SB?
That's a good question.
You're asking for, are there any specialists that you can have appointments with and work with?
Any kind of resources. I've gained weight in my 30s, right? It's natural part of aging. And the complications of SB and how those all interact.
Right.
And I'm not finding anybody who's familiar or online resources even.
That is really challenging. Did everybody hear that? It's really challenging to get adult-oriented care for many areas of people with spina bifida, and I think, unfortunately, the client needs to educate the educator a little bit about some of the issues that they're dealing with to help them tailor it to them.
So my follow-up then would be, how do I educate myself about my own nutritional needs? Because I've seriously, like, you go to the government website on the food pyramid and all of that, and there's not a whole lot.
Right.
And I know my calorie intake needs to be less than 2,000, maybe even less than 1,500, yet I don't know what it is.
Right,
And I
right.
can't seem to find that information.
What about, okay, so in our talk, we learned, I learned about the decreased lean body mass. And I don't know, I don't know what mine is. How do we know that? And would that be a place to start, to find out what your lean body mass is at this point and then work from there?
Possibly. I mean, I used to do a lot of that when I was younger. Haven't had it done
Because I don't know
lately.
even how to get that information.
Like BMI is
to-
not a good measurement for me.
I think you have to float in a pool.
No, I think it's challenging.
To get
I
a lean
think
body mass,
individuals, and I know you have a challenge, but unfortunately, I think our weight loss industry or just kind of counseling is lacking in so many areas. I mean, you see the literature, and it's difficult. There's always, I'm sure you've heard, the combination of energy in and energy out. So increasing your level of fitness can be very helpful to help raise your metabolic rate. And there might be just some up and down trials of different calorie levels if you're that detail oriented. So unfortunately, there's not that great of a easy solution to that.
There isn't a lot of good medical information really at this stage. I think for the adults, it's knowing what are the basics of an appropriate diet. The caloric expenditure thing is really a challenge. There are some people who are doing some work in that around the country, but a lot of that has not been published yet. They're in the new healthcare guidelines for spina bifida, which will come out this year. There is a section on nutrition across the lifespan for at least some guidance, but frankly, a lot of research still has to happen in that regard in spina bifida.
I would encourage you to check out the University of Washington Rehab Department. They may have a nutritionist. I'm guessing that they might, in terms of how they counsel people with physical disabilities.
So I have a question. Then are there any specific contraindications that you know of for adults who have spina bifida with high protein, low carb diets, or with using something called Contrave, which is really working for a lot of adult patients who need help, curbing their appetite? Somehow it helps them lose weight. It's a combination of Wellbutrin and opioid agonists. I forget.
I don't have any knowledge of that medication. Does anyone else have any knowledge on that? I typically, as far as, are you talking about like a ketogenic kind of diet, high protein? I typically cannot endorse that because it's usually like a short-term type of diet, and that you eventually have to kind of come back to eating differently. And so that's when the weight, if you lose weight initially, the weight will come off, but then it often comes back. And so it's not really a lifestyle of changing a lifestyle that I would usually recommend. So while it's tempting to do that and lose the weight, it's challenging to keep it off and to transition back to a more typical diet.
My question is, you'd said something earlier about how people with spina bifida lose a lot more water and a lot more calcium through urine. So how much more water should we drink, whether it's an adult with spina bifida or the kids, and how much more milk
Okay.
should we be drinking?
Well, it's not that you're losing more water. It's the calcium is excreted at a little bit higher rate than typical. So you're losing calcium. So it's good to make sure your diet is rich in calcium. And you can go up to the higher levels. I believe it's closer. It's like 1,500 milligrams a day. But other ways to measure your bone density and things need to be employed to, like anyone else, your bone mineral density testing and other things that you would have done as your routine health maintenance as an adult. Does anybody else want to?
So I have a question kind of down here in the second row. Kind of switching gears a little bit. You mentioned challenges with measuring BMI with kids with spina bifida. Has anyone in your departments been thinking about using mid-upper arm circumference to try to measure that?
There are alternate methods of estimating height. We at Children's Hospital have used kind of segmental measurements. I know other centers have used different measurements. That's one of them. Knee height is another measurement, but we haven't used those here. So as a program, Dr. Walker is raising his hand.
So in the children that we see in clinic, we try to get a height. We also do an arm span, which is a little better estimate of not taking. It tries to overcome some of the effect of decreased linear growth, particularly in the lower extremities for children with spina bifida. So we will use an arm span, and we also do a skin fold thickness, so it's a pinch. Other places have used mid-arm kind of things. The challenge becomes understanding the different distribution in terms of lean body mass, particularly that nothing really works great. And so there are, as Tim alluded to, there are actually some folks doing some studies using the pods and looking at body mass and trying to figure out other strategies of doing it. So we've used arm span and used the arm span with the weight to try and get a better idea about BMIs. It's more helpful sometimes in for the kids who are underweight, that we can give a little better explanation to the families. But there's just not great
Right.
strategies, at least at this point.
Yeah, and arm span, and this is challenging too, especially children with scoliosis. For him to be totally accurate, you have to be flat up against a wall. And how many people with spina bifida can be flat up against a wall? It's difficult.